So we can do this during yoga. Anytime you're doing breathing to relax, you can now pay attention to your transverse abdominis and your pelvic floor. And I didn't even notice that yoga had some verbiage that they just called a little bit different, like the bellows breath. That's when you do the slight force to exhale, like you're blowing the pinwheel, that will activate your TA and your pelvic floor. The Mula Bandha, or the root lock, is the perineal lifting action. The Uddiyana Bandha is the navel lock. That is our abdominal drawing in, right? Our belly button to our spine. And it's important to practice the navel lock with the root lock. So we want our pelvic floor and our transverse abdominis to co-contract, right? We're doing pelvic floor in yoga and didn't even realize it. So, yeah, the root chakra, if you're doing chakra, you can go through chakra balancing and work your pelvic floor at the same time. And that root chakra is located in the perineal floor. So there's a bunch of research on here that shows how it can help out our pelvic floor muscles, which is kind of cool. Another thing we can do is this Pilates breathing. And you're going to tie a TheraBand just around your rib cage to give a little bit of resistance. So we want to make sure we're set up in a neutral spine to start with. So our legs should be at a 90-degree angle, and our pelvis too. And we're going to inhale and prepare, and exhale to engage our transverse abdominis by lightly drawing in and lifting our pelvic floor. So the action is when we breathe in with expansion at lateral and posterior ribs. Exhale with pursed lips and gently push the air out. Keep your transverse abdominis and your pelvic floor active throughout the breath cycle, focusing on the lift of the pelvic floor muscle. Right. Our options is you can use your hands if you don't have a TheraBand, or you can do it just for biofeedback as well, and to improve the proprioception of the lateral costal breath. When you relax, and you can take the band off, you can go back to belly breathing. But if you can't, and you keep rib breathing, then you probably have high tone if you can't do it. Right, so, oh, I thought this was plain. I'm going to play this. Maybe I'll just take that off. I'll let you. Okay, I guess that was it. Okay, so another thing with our ribs is a forward rib cage usually goes hand in hand with other postural issues like lordosis and scapular winging. Here, this is how to check for your rib position. I'm going to go ahead and show this. This is to check for the rib cage. We have a wall test. So I will have my client bring their arms up and back and see if they can touch their forearms to the wall. And as you can see, the rib cage came up with her arms, and there's a gap in her lower back. Let's see, we can show right in there. So we'll have her come back, and we're going to instruct her to bring her rib cage down. And we already learned how to do that through our breathing. So when we take a deep breath, our diaphragm goes up, and when we exhale, it comes down, and our belly button comes in, and the rib cage gets pulled down with our transverse abdominis. And so we're going to have her kind of use her core to bring her rib cage in a neutral position while she does the same activity, and see if she can keep her low back against the wall. And that looks much better, right? So when lifting something over our head, we want to make sure we're doing that. And that also is why when we're lifting weights, we fill our lungs up with air when we're grabbing on, and as we engage and lift the weight, we're exhaling and bringing our rib cage down to protect ourselves, our low back, and not strain in the lumbar area. Yep. So she's got a little work to do there. Here's another one. It's the seated leg lifts or marching. Hi, we're going to do a little PNF for the torso rotators. To get started with that, we're going to ask our client if we can put our arm underneath and on the front of their shoulder, and then allow them to come down. This chair's lower, so I got to use my good body mechanics to get down with her. My other hand's going to go on the back of her opposite scapula, and we're going to instruct her to turn to the left here as far as she can, keeping her nose in line with her sternum. And then I'm just going to guide, and when she stops, I stop, and you can relax. If they keep holding it, they'll get a cramp in their rib cage. So at this point, after she's rested, she's going to go ahead and breathe normal, but she's going to resist with her torso, trying to come back to the right. It's natural for them to want to turn their head, but the nose has to be in line with the sternum. And I would count for a count of 5, which already would be that. And as she relaxes, I try to maintain that position. Then she's going to take a deep breath in. And on the exhale, she's going to turn back to the left on her own. I'm not forcing, and relax. When she stops moving, I have to give her permission to relax. So she just moved a couple inches. We're going to go ahead and resist one more time. 5, 4, 3, 2, 1, relax. No movement, big breath in, and on the exhale, if you're able to, twist more, and relax. When there's no movement or it's an abnormal angle, then we're going to be done and bring her back slowly to the beginning. And then I can do it on the other side. So I'm going to put my hand on the front of the shoulder. You can relax your arm. Other hand goes on the back of the scapula. And we're going to have them go ahead and twist to the right with your torso, nose in line with your sternum. And when she stops, I stop and you relax. You're going to go ahead and resist for a count of 5, 4, 3, 2, 1. Relax. Big breath in. On the exhale, stretch further if you're able. It's a big movement. And relax. So we want to make sure they're using their torso to turn and not their shoulder. She's doing great. I'm just pointing that out because it happens a lot. Go ahead and resist with your torso. 5, 4, 3, 2, 1. Relax. It's very strong. Big breath in. On the exhale, you can move. Good. Relax. And bring back to normal. Urinary urge or urge urinary incontinence, UUI. So it's UU or UUI is the next topic. It's when we have a strong urge to urinate. Not necessarily representative of a full bladder, and it's often paired with low volume voids. So you feel like you have to go really bad, but when you do, not a lot comes out, right? And we just think our bladder doesn't hold very much. Weak pelvic floor muscles, unable to adequately inhibit the detrusor muscle. That's what muscle is around our bladder that when it gets full, it contracts and gives a signal that it's time to void. And we might not be able to make it to the bathroom. A normal urinary frequency should be 8 voids a day, right? Some people get a signal that their bladder's full and then they go to the bathroom, eliminate, and all's good. But some people feel an urge that isn't even reflective of their bladder filling. They just went to the bathroom. They haven't had much to drink. And when they go, nothing comes out. And they're having some neurological misfiring. Some people get a signal and leak on the way to the bathroom. So they start to develop a pattern of going more often, even when they don't have to go. Sound familiar? So let's take a look at the physiology of micturition, which is the action of urinating. The bladder fills up at 15 drops a minute. Right? The first sensation to void occurs at 200 milliliters, but the bladder can fill up to 500 to 600 milliliters. So it might get stronger, and then another, and then another, and then they go away in between, and you should have plenty of time to get to the bathroom. Right? The detrusor has a sphincter reflex. When the sphincter, the pelvic floor muscles are active, the detrusor is inhibited. Smooth muscle is not voluntary control, but when the pelvic floor muscles contract, it will inhibit the detrusor. If the detrusor is uninhibited, it will give a strong urge, right? So what can we do? We can indirectly affect the detrusor. If you feel a strong urge, but there's no reason for it, you can relax, do some pelvic floor muscle exercises, like our elevator, and stop the detrusor. And over time, it will reset that neuromuscular pattern to do that on its own, right? So these people really don't need pelvic floor strengthening. They just need to get the right timing for their muscles that they already have. Right? Approximately 7 voids a day and 0 to 1 per night, and 2 to 5 hour voiding intervals. That's what the goal is, right? The length of urination should be a count of 8 to 10 seconds. Right? Are you urinating for 8 to 10 seconds when you go? Your pelvic floor muscles should relax and inhibit if the detrusor is released, and there's no need to strain. All right, relaxing actually helps. The color should be light yellow, and ideal water intake should be your body weight in pounds divided by 2, and that's how many ounces you should be drinking a day. Your body weight in pounds divided in 2 is how many ounces of water you should be drinking every day. Right? The male length of the urethra, the curves within the urethra help control leakage, right? If you look at how long this is compared to a female, right? So sometimes you can get some stuck in here, right? And then you get up and you can wiggle around and some comes out later. But female depends more on elastic connective tissue layers, including the periurethral musculature. The old practice to strengthen pelvic floor and done regularly would cause UTIs when you're stopping the flow midstream. They don't do that anymore because people are getting urinary tract infections, very painful, and it sends the wrong message to the brain. So do not stop the flow midstream. Instead, try this, right? Try to fully relax and allow all urine to empty. When complete, perform 5 to 10 pelvic floor contractions with full relaxation in between contractions each time you void. That way, every time you go to the bathroom, you're doing 5 to 10 reps of pelvic floor exercises. Right? This is useful for post-void dribble. And like I said, that urine can get trapped in there in that space. Before you leave the bathroom, you can do some Kegels to straighten the curve and, you know, get that last little bit out. But make sure you relax enough. And you can just get up, move your hips around a little bit, and then sit back down, and then do some pelvic floor contractions. We have to look at our behaviors too. Okay, so here's some good habits versus bad habits. You want to allow the bladder to completely fill and notice the sensation or urge and void accordingly rather than just in case voiding, right? If the bladder gets used to being tiny, that stretch sensors adapt, and then you have to go all the time. So the pelvic floor muscles completely relax, do not try to rush, versus straining to rush to get urine out faster and not emptying and relaxing fully. We don't want to squat and hover above the toilet seat, right? That's actually straining our pelvic floor and contracting it rather than letting it relax. We want to have adequate hydration spread throughout the day and then taper in the evening rather than not drinking anything all day long and then, you know, drinking a ton of water at the end of the day. That's not good either. Or waiting until the end of the day to void either. That's not good. And then also there's some irritants that can make you feel like you have to pee, and that's to get those toxins out, right? So if you have caffeine or carbonation, artificial sweeteners, that can concentrate your urine and that can really irritate it. And then add to that, you know, versus inadequate hydration, remembering to drink water at the end of the day or all at once, and drinking coffee and alcohol. There are voiding logs. You can either keep track of it yourself, but there are some apps that could help you. I found some at the App Store. The Voiding Diary, IUFlow, the PNC, the Bladder Pal 2, and My Bladder Buddy. They're all apps, and they keep track of the fluid intake, your food intake, the presence of irritants, how many times you've voided and the amount, the number of seconds with full stream of urine, 8's normal, how many bowel movements, what it looks like, were you straining, leakage, how and how much. Was it a small amount, a medium amount, a large amount? And when did it happen? Was it during activity? Did you have an urge to empty your bladder? A 0 to 3 scale, yes or no? Right? 0 would be no urge, just in case, or out of habit. Right? 1 would be awareness of bladder filling. 2, need to void, impending. And 3, I must go now. So by gathering some of that data and sharing it with a pelvic floor or, you know, therapist or a urologist or a gynecologist or whoever you're seeing, then they can have a little bit more information. So with the pelvic floor rehabilitation, indications for that would be pelvic organ prolapse, incontinence, difficulty emptying, constipation, urinary retention, before that, we need to know the contraindications. So if they have a catheter, In preterm labor, high-risk pregnancy, just due to lack of research. Immediately post-surgical, unless directed by the surgeon, or if there's cognitive impairment. Barriers to rehab is poor motivation, compliance, inadequate exercise, intensity and frequency, severe pelvic floor symptoms, or comorbidities, including obesity and cigarette smoking. So we got to look at pharmaceuticals or conservative treatment. Most primary care providers treat urinary incontinence using pharmaceuticals. Oxybutynin is an anticholinergic used to treat urinary incontinence, but the side effects include dry mouth, constipation, dizziness, blurred vision, delirium, and it's been linked to dementia. So the meta-analysis of non-surgical interventions for women with stress urinary incontinence, the cure rate is 73% and improvement of 97%. 46% of participants with urge urinary incontinence demonstrate success with 4 treatment sessions of pelvic floor rehab. And 50% or greater improvement in urinary incontinence frequency. So I hope I read that right, the research. So functional pelvic floor muscle exercises for urge, right? At some point the urge goes away and it comes in waves, right? So for training in the initial phases, you know, you can encourage the use of a pad, you know, like Depends or whatever, or Chuck's pad, you know, just for assurance so they don't worry. Or for those with weakness, maybe strengthening might be necessary to inhibit the detrusor. But our goal is muscle hypertrophy to increase strength of inhibition. So we're going to sit and let the perineum be supported. Stay calm and breathe. Perform quick pelvic floor muscle contractions. Contract 1 to 2 seconds. Relax the pelvic floor as fully as possible between contractions for 5 to 10 contractions or until the urge subsides, right? Like I said, urges come and go in waves. You may utilize distractions so the brain has something else to focus on, which will decrease its attention on urge sensation. For each contraction, count backwards from 100 by 7. If you can do that. Contract to the beat of your favorite song. When the urge subsides, calmly walk to the bathroom if you still need to. All right, we're building on that neurological communication. So we could do a Pilates leg lift where we're abducting our leg, and we can set up in a neutral side lying position, and bottom leg the knee can be bent, and we want to use our core muscles and pre-activate them to support the neutral spine. So on the inhale, we're going to keep our core active and breathe laterally. On the exhale, lift the top leg. As you exhale, you're going to lift the leg as high as possible while maintaining lumbopelvic stability. Inhale, return to the start. Exhale, lift the leg. Inhale, return to start. Exhale, lift the leg. Right? If the bottom leg is straight, we can just do the abduction, or we can kind of bend both knees and do a clamshell and do the same thing. If there's poor endurance, we can use pillows to support a neutral spine and perform some quick pelvic floor muscle TA contraction just prior to lifting the leg each time. Pop. not soda pop. Pelvic organ prolapse is the next topic. So it's actually more common than you would think. It affects more than 3 million women in the United States, and the prevalence is increasing. It's not as common for men, but it happens. Usually something traumatic, like heavy lifting, would do it. There's a lifetime risk for surgery to address either stress urinary incontinence or pelvic organ prolapse. That's 20.5%, and 30% of those will require repeat surgical repair. Pelvic floor muscle exercises reduces symptoms and slows the progression of pelvic organ prolapse and can reverse a grade 1 to 2 pelvic organ prolapse. Once I said that women lifetime risk is 1 in 5 and increasing, but most could be prevented if caught earlier, right? We can sometimes even reverse a grade 1 or 2 prolapse, but sometimes they're asymptomatic. So we don't even know that we have it. But that is something, like I said at the beginning, that a provider could check at an annual exam. Just, check for it. Do a screening. Here you can see a grade 1 of a bladder prolapse. Right? And you can see here on the picture where that's where it's supposed to be, up here. And so it's way down here. Grade 2, it's starting to come out the vagina. And grade 3, it's already down past here, right? So pelvic organ prolapses are not easy to find in a recumbent, right? Seated or semi-reclined position or supine, laying on our back. But how do we get exams to screen for this? So if the only time you're having symptoms is when you're standing or running, maybe you need to get off the table and have them examine you while you're standing or jump up and down, right? We can also have prolapses with the uterus. We can have prolapses with the rectum, and we can have it with the small intestine. Okay. So why? This is the etiology of pelvic organ prolapse and stress urinary incontinence, right? So there's some intrinsic factors. Abnormal collagen matrix results in pelvic organ prolapse and sudden, I'll just say SUI. People with connective tissue disorders such as Ehlers-Danlos and Marfan syndrome have a high rate of urinary incontinence and pelvic organ prolapse, 20% higher than control. Genetics, those with a grade 3 or 4 prolapse have a 5-fold higher occurrence in members of their family. Their age is a factor. Advancing in age increases the risk. And ethnicity. So studies show that Latino women have the highest rate of stress urinary incontinence at 67%, whereas Latina and white women had a 4 to 5 times the risk of symptomatic prolapse compared to African American women in this study. All right. So sometimes you're born with it, and sometimes there's other factors, genetics and all that. And there's also extrinsic factors, right? Like pregnancy, the weight of the baby, right? Estrogen affects our tissues. But the parity, regardless of vaginal or cesarean delivery, perineal descent at term causes the pudendal nerve motor latency. So that nerve is what's in our perineum, and you just have the weight of the baby down there. That's enough, right? Hysterectomy disrupts the fascial layers. Hormone replacement therapy, right? Patients on hormone therapy had 50% higher odds of urge incontinence and 70% higher odds of stress incontinence. So that estrogen can affect as well. Then we have comorbidities that create chronic and intra-abdominal downward pressure, meaning obesity. There's a 3% increase of incontinence with every 1 unit increase in your BMI. Chronic pulmonary disease, chronic constipation due to repetitive bearing down for a bowel movement. Smoking increases the prevalence by 56%. Or an occupation that requires heavy lifting. So also we could do pre-physical therapy before a hysterectomy to help. Laparoscopic surgeries will affect tissues too. So any kind of time that it is a necessity to get surgery, it wouldn't hurt to be doing some pelvic floor muscle exercises prior to that to get a head start. So should women with incontinence and prolapse do abdominal curls, right? Depends. Some can and some can't. Really, really need an individualized attention in this. But the conclusion in the studies said that the large variability in intra-abdominal pressure generated during an abdominal curl and a cough was the other thing, suggested that some current recommendations may be unnecessarily restrictive in some women, but important in others. Advice for women with pelvic floor dysfunction undertaking tasks that increase any kind of internal abdominal pressure needs to be individualized. Female athletes, right? So stress urinary incontinence is a barrier to women's participation in sports and fitness activities, and therefore it may be a threat to women's health, self-esteem, and well-being. The prevalence during sports among young nulliparous elite athletes varies between 0%, like golf, and 80% in, guess what, trampolines, jumping up and down. That's not surprising, is it? The highest prevalence is found in sports involving high impact activities like gymnastics, track and field, and some ball games. A strong pelvic floor may be a crucial factor in counteracting the increases in abdominal pressure occurring during high impact activities. Use of preventative devices such as vaginal tampons or pessaries can prevent leakage during high impact physical activity. Pelvic floor muscles need to be much stronger in elite athletes than in other women. So to begin with, we recommend mild to moderate physical activity such as brisk walking. That decreases both the odds of having and the risk of developing urinary incontinence. In older women, mild to moderate activity decreases the odds of having fecal incontinence. Right? Moving around more, sedentary doesn't work. And young women participating in high intensity activity are more likely to report anal incontinence than less active women. So they might need a pessary when doing high impact sports like jumping. There's products like Poise or the Impressa, and the pessary, it goes in kind of like a tampon, the same way how it kind of sits above the layer of muscle and doesn't interfere with any kind of strength training. But having that pressure there of that device does prevent leakage. And I know a lot of people who have done that when they're in these sports. And this is where we also want to do the Kegel, the functional Kegel, right? So we want to determine the functional activity that brings on the symptoms of sudden stress, urinary incontinence, and pelvic organ prolapse. I'm going to teach co-contraction of your pelvic floor muscles and your transverse abdominis in supine, sitting, and standing. Teach pelvic floor muscle and transverse abdominis endurance hold with simple movement that integrates deep core stabilizers into global task, ideally a component of the functional task. Integrate pelvic floor muscle and transverse abdominis into functional, meaningful tasks. And the pelvic floor and transverse abdominis co-contract exercises. Right, so first we want to learn how to do them like we've done in this workshop, but once we know how to do that, we can do an exercise where we're standing and doing it. We're going to stand and co-contract. And once we get that done, then maybe we can stand, co-contract, and squat. Or stand, co-contract, and jump. Right? And of course, release in between. Or we can lay down with our knees bent and co-contract. Or we can put our feet on the floor while we're laying down and try to do that while we're bridging up and bridging down and then relax, right? I'm gonna co-contract, bridge up, bridge down, relax. Or we can just contract on the way up and relax on the way down. Those are all different ways we can do functional Kegels. We have to look at intra-abdominal pressure during fitness and function. Most basic Pilates, mat and reformer Pilates exercises, they do not significantly increase intra-abdominal pressure. The exercises were compared to intra-abdominal pressure of sit to stand, right? And intra-abdominal pressure with pelvic floor dysfunction. Do post-operative restrictions make sense, right? So there is more in study intra-abdominal pressure generated during a cough or a sit to stand task than lifting a 20-pound weight, right? So we're talking about somebody who has surgery and they're restricting them from doing any kind of exercise. Or maybe postpartum, somebody just had a baby and they're saying that they should wait 6 to 8 weeks before returning to exercise. Well, when in study, just sit to stand is increasing intra-abdominal pressure. It's one of the hardest things to do. How many times do you do that? If you can stand, yeah, or how about lifting a baby that weighs 7 to 10 pounds most of the time, right? So yeah, you really can start working the pelvic floor immediately, doing that co-contraction type of exercises. And we can also work on our torso rotators to increase some muscles that are hanging on to relax them. And so I'm going to do that just to break up this lecture a little bit more and show you some torso rotator exercises that you can do, maybe some PNF and something to do during body work. Okay. This is going to be the PNF one. Hi, we're going to do a little PNF for the torso rotators. To get started with that, we're going to ask our client if we can put our arm underneath and on the front of their shoulder and then allow them to come down. This chair is lower, so I got to use my good body mechanics to get down with her. My other hand's going to go on the back of her opposite scapula, and we're going to instruct her to turn to the left here as far as she can, keeping her nose in line with her sternum. And then I'm just gonna guide, and when she stops, I stop, and you can relax. If they keep holding it, they'll get a cramp in their rib cage. So at this point, after she's rested, she's gonna go ahead and breathe normal, but she's gonna resist with her torso, trying to come back to the right. It's natural for them to want to turn their head, but the nose has to be in line with the sternum. And I would count for a count of 5, which already would be that. And as she relaxes, I try to maintain that position. Then she's gonna take a deep breath in. And on the exhale, she's gonna turn back to the left on her own. I'm not forcing, and relax. When she stops moving, I have to give her permission to relax. So she just moved a couple inches. We're gonna go ahead and resist one more time. 5, 4, 3, 2, 1, relax. No movement, big breath in, and on the exhale, if you're able to, twist more, and relax. When there's no movement or it's an abnormal angle, then we're gonna be done and bring her back slowly to the beginning. And then I can do it on the other side. So I'm gonna put my hand in the front of the shoulder. You can relax your arm. Other hand goes on the back of the scapula. And we're gonna have them go ahead and twist to the right with your torso, nose in line with your sternum. And when she stops, I stop and you relax. You're gonna go ahead and resist for a count of 5, 4, 3, 2, 1, relax. Big breath in. On the exhale, stretch further if you're able. It's a big movement, and relax. So we wanna make sure they're using their torso to turn and not their shoulder. She's doing great, I'm just pointing that out because that happens a lot. Go ahead and resist with your torso. 5, 4, 3, 2, 1. Relax. Just very strong. Big breath in. On the exhale, you can move. Good. Relax. And bring back to normal. Okay. This is one in the massage area that always feels really good just to work those ribs.